Hello guys, welcome to the Parson series, and this is part 5 of glaucoma. Now we have already discussed the primary open angle glaucoma, we have discussed the angle closure glaucoma. Today we are starting with the combined mechanism glaucoma. Now what do you mean by combined mechanism glaucoma? This is a term to denote the eyes in which you have got a occludable angle with a few peripheral anterior synecdoche, and it is of such an extent that alone it does not explain the raised intraocular pressure or the glaucomatous damage. So this means that there is something extra which is going on in this eye which has an occludable angle with very few of the peripheral anterior synecdoche, and that actually denotes the combined mechanism. So thus there is a possibility that the patient may have some underlying trabecular changes of the open angle glaucoma, patient may have the angle closure, and it can be incidental also, it could be additive also. Now having said that, we are coming to the secondary glaucomas, which is again a very important topic, and many of the times you are actually having the patients having secondary glaucomas because it is occurring as a complication to the other ocular diseases. So when you are talking about inflammation, when you are talking about the long-standing retinal detachment, you can end up causing the secondary glaucomas, right? So these form a large proportion of the glaucomas seen in the practice, especially the developing countries like ours. And why this is occurring, as I told you, because there is a high incidence of ocular infections, inflammations, complicated cataract surgery and trauma. So basically these are the important causes of your secondary glaucoma whenever we are having the patient suffering from ocular infections and inflammations and trauma hai, surgery hai, we can have actually the secondary glaucomas, and the attending ophthalmologist treats the primary cause but often an undiagnosed secondary glaucoma. So whoever is the attending ophthalmologist, he treats the primary cause, okay, but he is not looking into that there is a secondary glaucoma also which is occurring that can lead to substantial loss of vision, and if the specific therapy is not given, okay, even before it is identified, even before the specific therapy given, it can lead to substantial loss of vision. All right, now let's talk about the pathogenesis first. So pathogenesis, what are the common causes of secondary glaucoma? They can vary from region to region depending upon which diseases are common in that particular area. You can divide this into the angle closure glaucoma or the open angle glaucoma that you can see with the help of gonioscopy. So gonioscopy actually remains an important measure whenever we have to find out that it's an open angle glaucoma or it's angle closure glaucoma. And we have got various pathologies which are affecting the outflow channels of the eye. They may be classified into those causing iris to be pushed or pulled forward, leading to angle closure glaucoma. So whenever you have sudden closure of the angle of anterior chamber, you can have pushing of the iris towards the cornea, or you can have pulling of the iris. Both of them could be there, and both of them can lead to sudden closure of the angle of anterior chamber, or those that are affecting the trabecular meshwork itself also. So it could be by the fibrosis also, and important thing about fibrosis is that when you are seeing the angle in the gonioscopy, you will see that angle remains open there. Alright. Now, let us see the common causes of the secondary glaucomas. They are more often in the eyes which are predisposed to glaucoma. Now, though here we are not having the primary glaucoma, we are having the secondary glaucoma, but it has been seen that this is occurring more common in those eyes which are having the predisposition towards the glaucoma. We can have a family history or the certain risk factors which are present. The treatment is usually that of the primary cause, followed by the control of intraocular pressure to the individualized target pressure. So one thing which is important is that we often discuss that in cases of primary glaucoma, when you do not know the exact causes, often we have some risk factors, some family history, some hereditary predisposition, some genetic outlook, but it is also in the secondary glaucoma. So those people who are developing glaucoma as a complication of some of the factors, they are also affected by the family history, they are also affected by the predisposition, they are also affected by other risk factors. Now, first of all, we start with the inflammatory glaucoma, because I think this is one of the most common causes of secondary glaucoma, and if you look at the incidence of The inflammatory pathologies, they are again quite common. So the first is your uveitic glaucoma, right? Uveitic glaucoma is occurring due to the swelling and dysfunction of the endothelial cells, or we can have the cells of infiltration or obstruction of the trabecular meshwork by the inflammatory cells. Now, if you remember the basic definition of open angle glaucoma, it is the trabecular blockade. And I told you the word trabecular blockade itself says that the angle is open, because if the angle is closed, trabecular meshwork blockade could not take place. So, it is just that which cells are blocking the trabecular meshwork, you can say which type of secondary open angle glaucoma it is. Like if it is by the inflammatory cells, it is inflammatory glaucoma. If it is by pigmentary cells, it is pigmentary glaucoma. So when I am having the obstruction of the trabecular meshwork by the inflammatory cells, it is called as inflammatory glaucoma. It could be white cell aggregates, it could be macrophages, it could be lymphocytes, or it could be fibrin, and all this will lead to the decrease in the aqueous outflow. It will lead to the diminished outflow, and subsequent there will be increase in the intraocular pressure. Now, inflammatory material will be seen as a precipitates, and this will be called as a secondary open angle glaucoma. Important thing is that whenever you are getting such type of glaucoma, how to find out that whether it is open angle or whether it is angle closure. So, important thing is always see whether it is causing the trabecular outflow blockade or not. If at all it is causing the blockade of the trabecular meshwork, you always have to consider that it's a open angle glaucoma. Now, do you know the cause of this blockade? If no, it's a primary open angle glaucoma. If you know the cause, it is a secondary open angle glaucoma. It is as simple as that. Now, second entity is your post-inflammatory glaucoma. Now, once the inflammation is subsiding, right, the extensive posterior synechiae is going to take place that will cause the occlusio pupillae or the seclusio pupillae. So, whenever you are having the cases of pupillary block due to the synechiae taking place after the cases of the inflammation, we will have the formation of the iris bombay and closure by the synechiae. I will explain you. It is something like this. Suppose this is your cornea, and we have the iris here, we have the ciliary body, and this is your lens. Now, normally whatever aqueous humor is getting released here, it is going anteriorly, it is going in the anterior chamber, going to the angle of anterior chamber, and then 90% is passing through this trabecular meshwork. This is the normal one. Now, whenever I have seclusio pupillae, you have occlusio pupillae, aqueous humor is not able to pass through it. So, what is happening now? This area is actually blocked. So, this area is now blocked. So, what is happening? This of the aqueous humor is pushing the iris. So, when it is pushing the iris anteriorly, iris is going to have the ballooning. This kind of ballooning of iris will take place due to the collection of aqueous humor behind. So, this ballooning of the iris and touching the iris over the cornea, this is actually called as the iris bombay formation. This is called as the iris bombay formation, which will lead to sudden closure of the angle of anterior chamber, and obviously it will lead to the acute congestive glaucoma. Now, once this sudden closure has taken place, we have the contact between the iris and cornea. There starts the formation of synechiae, and we start having the synechiae between what you called as the iris and the cornea, and it is something like this. So, we have the formation of the synechiae here. This synechiae is formed. These are called as the peripheral anterior synechiae that is passed. Now, once the synechiae has taken place, this is a kind of chronic closure or a permanent closure till you do the surgery, because synechiae won't resolve. So, this is one time where your miotics won't help. This is one time where iridectomies and iridotomies do not help, and that is why the treatment of choice in cases of chronic congestive glaucomas remains the surgeries only, and this will lead to the synechial angle closure glaucoma called as chronic congestive glaucoma. So, I hope the mechanism is very, very clear, right? So, once again, if I read this slide, once the inflammation subsides, we have extensive posterior synechiae that can lead to occlusio seculi, then seclusio pupillae, iris bombay, and the angle closure will be done by the peripheral anterior synecdoche. Now, even without extensive synecdoche, repeated episodes of iridocyclitis can also cause fibrosis and obstruction of the meshwork. Now, this is one of the mechanism where the synecdoche formation was taking place. Now, even though I do not have synecdoche, then also I can have the glaucoma due to the recurrent episodes of uveitis, because they are going to cause fibrosis, they are going to cause the obstruction of the trabecular meshwork. Alright. So, this is your case where you can see it's a healed case of anterior uveitis, and you can definitely see the synecdoche here. We have got 360-degree posterior synecdoche, we have got the iris Bombay formation. There is a, can you see the convex areas of the iris here? So, this is actually the ballooning of the iris, and a large laser iridotomy has been done. This is the laser iridotomy which has been done. This is your laser iridotomy in order to relieve this pupillary block. This has been given. Alright. Now, another important, because you know the symptom, systemic syndromes which are related to the inflammation and glaucoma are really important. So, one such kind of syndrome is your glaucomatocyclitic crisis. Glaucomatocyclitic crisis, which is also called as the Postinflammatory syndrome. This is acute, recurrent, very mild uveitis which is giving you a secondary glaucoma. It is the glaucoma which is presenting out of proportion to the amount of inflammation. I think this statement is really very important. If you are having a glaucoma which is out of the proportion to the inflammation, you are not having that much of inflammation that can justify this glaucoma, probably you are dealing with a case of glaucomatocyclitic crisis. We have unilateral mild discomfort, then some amount of blurring of vision, halos, but important thing is it will be a white eye with the open angle. You are definitely going to have a white eye. So, if you are having inflammation, you are having glaucoma, unilateral, mild discomfort, blurring of vision with white eye, and angle is open, there is no congestion, probably you are dealing with this syndrome. The intraocular pressure will be very high. Now, can you see the contrast? Intraocular pressure is very high, but the eye is white and angle is open. It is between 40 to 50 mm of mercury. The inflammation is minimal with some aqueous flare, occasional cells, and non-pigmented keratic precipitates. So, though the amount of glaucoma is more, you are having 40 to 50 mm of mercury, but you will not get that amount of inflammation in the person. Posterior synecdoche, and then another important thing, posterior synecdoche or anterior synecdoche do not form. Again, an important thing, because same happens in the Fuchs heterochromic iridocyclitis also. You are not going to have any kind of synecdoche there. The inflammation often manifests several days after the intraocular pressure rises. Now, again important thing, here it is not that first the uveitis is coming and that is leading to the raised intraocular pressure. First you get the raised intraocular pressure, and after several days you have uveitis, and you then came to realize that actually it is a secondary glaucoma. The attacks resolve in days to weeks, but recurrence is common. They have not mentioned it, but its other name is the Posner-Schlossman syndrome. So, at times it may be a possibility that you are getting this question by this Posner-Schlossman syndrome. It is a glaucomatocyclitic crisis. So, go by the name. First you have glaucoma, then you have cyclitic, that means then you have uveitis. It's a crisis where glaucoma is out of the proportion of the uveitis. You are having such a high intraocular pressure, inflammation is minimal, you are having 40 to 50 mm of mercury, you are not having any congestion, eye is white, angle is open, and you will have the non-pigmented capes. This is usually unilateral and found in males. Now, a similar kind of condition is there, which is called as the Fuchs heterochromic iridocyclitis. Now, if you look at this condition, Fuchs heterochromic iridocyclitis, this is a condition which is somewhat different from this Posner-Schlossman syndrome, in that this is slightly more common in females. Here you have a lot of iris signs, and here you know, you are having a typical kind of capes. These are called the stellate capes. So, this consists of a chronic low-grade iritis with posterior subcapsular cataract is there, secondary glaucoma is also there. And again, like the Postinflammatory syndrome, this is also unilateral in 90% of the cases. It is found in within 3 to 4 decades, and a very important thing is that it is associated with the change in the color of the iris. So we have heterochromic iridocyclitis. So if the iridocyclitis is associated with the heterochromia, it is associated. Heterochromia means different color of the iris, and out of this different color, you have to remember that it is the lighter color iris. So the involved side, because you know it is unilateral, so affected side is showing you the lighter color iris, because many a times you are having the heterochromia of the iris, but then the involved iris is darker colored, like it could be due to the involvement of prostaglandins. But when you are having this Fuchs heterochromic iridocyclitis and you have heterochromia, the unilateral side, the involved side will have the lighter color iris. The inflammation will consist of the low grade Freyer and cells, so that will be same. We are having low grade inflammation, but typically we are finding the stellate capes. We have spillover anterior uveitis. What do you mean by spillover anterior uveitis? That means the filaments scattered all over the endothelium. Anterior opacity, vitreous opacities could be there. Secondary glaucoma is presented in about 15% of the patients, and obviously vision will decrease because the cases of cataract are also there. So if I compare, I have little more amount of inflammation as compared to the glaucomatocyclitic crisis. I have the secondary glaucomas, I have the cataract here also. We have heterochromia of the iridis, we have stellate capes, unilateral, 3rd to 4th decade, females. Then we also have the absence of posterior synecdoche, iris nodule, iris rubeosis, that is your neovascularization of the iris, trophic patches, again means you get a lot of iris signs in these cases, and this is the important thing, how you can differentiate between a Postinflammatory syndrome and the Fuchs heterochromic iridocyclitis. Alright, control of the uveitis we can do with the topical steroids, we can give the antacids, this is a priority. The intraocular pressure is initially reduced below 20 by the medical means, and then glaucoma therapy is re-evaluated once inflammation subsides according to the visual field loss. So again, a condition where you are giving a benefit of the topical steroids. Now though we are having glaucoma, but still we give the topical steroids here, we give the antacids. Our aim is to decrease the intraocular pressure to less than 20, and then we can re-evaluate the treatment. So I think this inflammatory glaucoma is very clear, very important, two important syndromes. Now we come to the other one, that is your neovascular glaucoma. Neovascular glaucoma is actually following extensive retinal ischemia, and it is commonly seen in association with the CRVO as well as PDR. Now whenever we are talking about the neovascularization, I think nobody will deny this fact that diabetic retinopathy is the first thing that is coming to your mind. It's a microangiopathy, and you have maximum ischemia there. Because of the maximum ischemia, I will have maximum VEGF and maximum neovascularization, and that is why PDR is probably the most common etiology of the neovascular glaucoma. But the second in the list, which is not very far away, is your CRVO, and that too specifically the ischemic CRVO. So when I am talking about the ischemic CRVO, as the name suggests, which is sufficient enough to cause the ischemia, which is not reversed by the anastomosis or the collaterals, is again leading to release of lot of VEGF, and that leads to neovascular glaucoma in about 90 to 100 days, and that is the reason why this is called as 90-day glaucoma or the 100-day glaucoma. So let us go by reading. It is due to the presence of neovascularization. This neovascularization is actually taking place over the iris. Now why this neovascularization is actually leading to glaucoma? Because this neovascularization is actually taking place over the iris. This is your cornea, this is your iris, lens. So we have a lot of neovascularization which is actually taking place over the iris. This is called as rubeosis iridis, and due to this rubeosis iridis, we have got zip-like adhesions which are formed. So these are your zip-like adhesions which are formed in the angle of anterior chamber, due to which we have got the sudden closure of this angle of anterior chamber, and this is actually responsible for causing the glaucoma that we call as neovascular glaucoma. Neovascular glaucoma remains a difficult problem, and we need anti-VEGF agents, because obviously neovascularization is occurring due to the vascular endothelial growth factor, and we require photocoagulation, cryotherapy, all this to eliminate the stimulus, right? The raised intraocular pressure can then be elevated by a trabeculectomy in conjunction with the antifibroblastic agents and anterior chamber drainage implant. So basically, I think this is again very important, because the pathogenesis which is causing this neovascular glaucoma is very important. The conditions where it is present is very important. So you will definitely be asked the diabetes and the diabetic retinopathy in every of your question and in every of the exams. So I think one of the complications which could be neovascular glaucoma is again a commonly asked topic. Neovascularization, rubeosis iridis, zip-like adhesions, ischemia, neovascularization are the important things which are concerning its pathogenesis. So we do require the anti-VEGF agents, antifibroblastic agents. We need to coagulate the vessels. We need to give cryo to the eye. We can even do the surgery, trabeculectomy. Along with this, I have to give the antifibroblastic agents. Maybe the drainage implant is also required. So this is a case of your neovascular glaucoma, where you can see the vessels which are growing over the iris. This is your rubeosis iridis, right? Now, another important thing is your lens-induced glaucoma. Again, I think this is a very important entity, taking into consideration that cataract is such a common cause of blindness in India. Now, because of this glaucoma also, because we have the lens-induced glaucoma, again it adds to the percentage of the blindness that it is causing. Now, secondary angle closure, how it is leading to the angle closure type of glaucoma. Let's see this. It can lead to the angle closure type of glaucoma under two circumstances. First of all, when your lens is intumescent. Okay, if you remember, we always read about the immature senile cataract. So when we have the immature senile cataract, we are in the early phase of hydration, and we have got more and more hydration actually leading to the swollen lens. So as the lens becomes swollen and swollen, it absorbs more and more fluid. The stage of intumescence is achieved, and if it is something like this, okay, and we were having the lens something like this, it actually swells like anything. It swells up. So when it is swelling up, it is occluding the area through which the drainage of the aqueous humor had to take place. Now the aqueous humor is not able to pass through, and because aqueous humor is not able to pass through, this will give me the obstruction in the flow of aqueous humor, and this is leading to glaucoma. Now, because this glaucoma is occurring due to the changes in the morphology of the lens, this is called as your phacomorphic glaucoma. So, the lens becomes intumescent. Why it is becoming intumescent? Either we have got the rapid development of cataractous changes, or we can have traumatic rupture of its capsule. Due to any of the reasons, it is absorbing more and more fluid. The swollen lens is then obliterating the drainage and it is forcing the root of the iris to come in closure with the angle, and that actually is called as phacomorphic glaucoma. Very, very important condition. Phaco means lens, morphic means morphology. So the glaucoma which is occurring due to the changes in the morphology of the lens is your phacomorphic glaucoma. Unless the condition is rapidly relieved by the surgery, we have extensive peripheral synecdoche that is causing a permanent rise of the intraocular pressure, and even if the lens is subsequently removed or gets absorbed, you are having a lot of problems. So if you remember the different stages of the cataract, we have first of all lamellar separation. After the hydration, we have incipient cataract, immature senile cataract, mature senile cataract, hypermature senile cataract. So in every stage we have the risk of glaucoma, and that is why we are insisting for the early surgeries. Another important thing is that we can have the anterior subluxation or the dislocation of the lens. So when does it happens? When we have the sclerotic type of hypermature senile cataract. In this sclerotic type of hypermature senile cataract, when I have got the disintegration of the lens. Now let us assume another condition where I am having this iris here, we are having the ciliary body, and I am having this lens. This is the nucleus part. These are your zonules, something like this. Now, if I am having this disintegration of the cortex, if I am having this disintegration of the cortex, lens becomes very small and shrunken, something like this. So, obviously, this leads to the degeneration of the zonules, and the main need of the zonules is that it is causing the stability and it is holding the lens at its proper position. So, the moment the zonules are gone, lens is free to actually dwindle. So, it starts moving like this. This is your subluxation. If we have got the seesaw motion. So, now if the lens is actually moving, this is your subluxation. That means it's only the partial displacement. It can go anteriorly also, it can go posteriorly also. So, if it is going anteriorly, this is your causing narrowing of the angle of anterior chamber, and obviously when it is causing narrowing of the angle of anterior chamber, this is causing glaucoma. This glaucoma is called as the phacotopic glaucoma. So, this glaucoma is actually occurring due to the changes in the position of the lens. So, there is a difference between phacogenic glaucoma, phacolytic glaucoma, phacomorphic glaucoma, phacotopic glaucoma, phacotoxic glaucoma, phacoanaphylactic uveitis. There are so many things, right? So, I think this is clear. So, let's read what they are saying. In the partial subluxation, large segment of the angle of anterior chamber may be compressed. This is what I have explained you. It is coming anteriorly. In complete dislocation, the entire angle is blocked, and this glaucoma is called as phacotopic glaucoma. Phaco means lens, topic means position. Now, we have got another thing where we can have the secondary open angle glaucoma due to this lens. So, this may develop when we have another kind of cataract, that is your Morganian type of hypermature senile cataract. Now, what is taking place there? Suppose this is your cornea and we have the lens here. This is something like this, okay. Now, we have got a capsule also that is intact here, and we have got this brownish nucleus. Now, can you see if I am having the lysis of the cortex proteins, and because this type of cataract is chalky white or milky white in color, so let me make this lens chalky white or milky white, something like this it is happening. So, what is happening? We have got the lysis or liquefaction of these proteins, and this capsule, the capsule is intact. So, the capsule is intact here. So, what is happening? These cortex proteins are coming out. So, already what we are having here is the aqueous humor, and now the cortex proteins are also coming out, okay. And what is happening? The nucleus is actually settling at the bottom here. Nucleus will come at the bottom, proteins are coming out, there is a lysis, and where will they go? They will go and they will block this trabecular meshwork. So, they are going to block this trabecular meshwork, and therefore, they are causing secondary open angle glaucoma. This is called as your phacolytic glaucoma. Phacomorphic, phacotopic we have already done. I hope you are understanding this also. So, what they are saying that if the lens is damaged, your lens proteins are coming from a hypermature senile cataract, they will go into the aqueous and they will block the trabecular meshwork through which 90% of the drainage has to take place. So, this is your phacolytic glaucoma, it is obstructive, and cortical lens matter. You know that lens mainly consists of proteins, and these proteins contains the sequestered antigens. These proteins contains the sequestered antigens. So, they actually excite a large number of phagocytes, and these phagocytes will engulf the lens particles, they are swept into the trabecular spaces, they block the aqueous outflow. So, in total they are blocking the aqueous outflow, 90% of the drainage block. So, this is the secondary open angle. Careful examination reveals an active and free pupil with cells in the anterior chamber and the keratic deposits on the back of the cornea that shows that it is inflammatory in origin, okay. So, this is your phacomorphic glaucoma. You can see the swollen lens here which has obstructed the pupil, right? This is phacomorphic glaucoma. While on the other hand, this is your phacolytic glaucoma. Can you see the difference here? Can you see the liquefaction of the cortex? We can see the transparency here. While if you look here, this is completely white. So, that is the difference between your phacomorphic as well as the phacolytic also, right? Okay, now let us talk about the treatment part. Treatment of the lens-induced glaucoma is by extraction of the lens after lowering the intraocular pressure by medical therapy. Now, again very important. First treatment to be given and the most important treatment. Obviously, the most important treatment is your extraction of the lens. We will have to extract the lens because it's a lens-induced glaucoma, but it is not the first thing to do because first you have to lower the intraocular pressure. You cannot do any intraocular surgery on the high pressures. So, we will have to lower down the intraocular pressure by the medical agents and then go for the extraction of lens. So, at this particular aspect, examiner can play with words and you have to be very careful what question are they asking, whether they are asking you the first treatment or the treatment of choice. All lens beta has to be evaluated. If you talk about the PCIOL, that is not contraindicated. So, you can give the PCIOL here. If not treated early, outflow channels can be blocked. Long-term glaucoma medications or glaucoma surgery may be required for a chronically raised intraocular pressure. Now, if you are not treating it at the right time, then that can lead to chronically raised intraocular pressure, and then you have to actually carry on with the long-term medications as well as the glaucoma surgery. Alright. Now coming to the next entity, which is again very important, this is your pseudophakic or aphakic glaucoma. Talking about the pseudophakic glaucoma or the aphakic glaucoma, these are the common secondary glaucomas, and why? Because we are performing large number of cataract surgeries. So obviously every day so many people are becoming aphakic and pseudophakic, and if we are having a secondary rise of intraocular pressure after the cataract surgery, it can be attributed to the complications of surgery, and I can say that this is the pseudophakic glaucoma or the aphakic glaucoma. This is seen most commonly after the surgery for the pediatric cataract and following the use of ACIOLs. Again, a very important question. The pseudophakic glaucoma or the aphakic glaucoma is very common after the cataract surgery in the children as well as in adults after you are doing the ACIOL. Now, a secondary open angle glaucoma or the rise of intraocular pressure after the surgery usually resolves spontaneously within few weeks to the day or the days if it was caused by the use of viscoelastics or it was just the distortion of the angle structures, tight limbal sutures we have given, or it can be a reaction or a hemorrhage. So, these are again important things. These are the common causes that can lead to the rise in intraocular pressure after the surgery. What we can have, it can be due to the use of viscoelastics, tight sutures, postoperative reaction, distortion of the angle. All these things can lead to, but if it is only due to these causes, then most of the times it will can better by itself and within the days or the weeks. The management of this transient rise of intraocular pressure, you can treat it with the topical or systemic drugs together with the corticosteroids because you have got the inflammation also. So, most of the times we are getting it right. But in some cases what is happening now that the intraocular pressure stays chronically elevated or it may even rise several years later in the pediatric cases, and thorough investigation is actually required in those cases in order to find out the important cause. Secondary angle closure glaucoma. Now, if I talk about the secondary angle closure glaucoma, this can occur due to the pupillary block. We can have posterior synecdoche due to the intraocular lens or the vitreous phase, which is actually going forward towards the iris. So, we can have the cases something like this also. And for this, for the breaking the posterior synecdoche, we have got mydriatics. But if you are feeling that it is not successful, then it is mandatory to do a large NDX laser iridotomy, even multiple iridotomies to open the loculated pockets of aqueous humor. So, if you have the multiple synechial adhesions which are taking place, then what happens? Many times you have to create the iridotomy or even multiple iridotomies because there is so much amount of aqueous humor which is collected behind the iris that they have formed the pockets like. So, breaking the pupillary block early prevents the structural damage to the trabecular meshwork, because if you are not breaking this block, then slowly and gradually there will be structural damage to the trabecular meshwork. Today it is just the angle closure glaucoma, tomorrow it will also be complicated by open angle glaucoma, and it will also help the glaucoma to subside if the pupillary block has been present for more than a couple of days, a chronic rise of intraocular pressure is likely, and that will persist even after the iridotomy, must be treated with the anti-glaucoma medications. And a very important thing, this post-operative pupillary block is very common in the diabetic people. There are so many things which is actually common in the diabetics. So whenever you are solving the clinical question, these things should be taken in mind, that post-operative pupillary block is again very common in the patients of diabetes. Okay. Now coming next, a chronically raised intraocular pressure in the presence of a open angle. If you are having a chronically raised intraocular pressure and the angle is open, then what are the things that you are going to think? Due to the presence of retained cortical lens material, it could be a pigment dispersion, vitreous in the anterior chamber, fibrosis of the trabecular meshwork. Again, an important thing, suppose you are given a clinical scenario where you are having chronically raised intraocular pressure, but the angle is open, then what all are the things that you can think? You can think about the retained cortical matter, you can think about pigment dispersion, any free vitreous present in the anterior chamber, the fibrosis taking place in the trabecular meshwork. So that means there are so many things. The treatment would be as for any open angle glaucoma, medications, trabeculoplasty, surgery, all these things could be there. You can even get the transient rise of intraocular pressure in about half of the eyes who are undergoing NDAC laser capsulotomy. So what you can do, if it is only just a transient rise, it's okay, but if you are suspecting that this could take place even for a longer, we can give the apraclonidine for those cases where we are suspecting the rise in intraocular pressure after the procedures. Then another thing that we can use is a systemic harmonic anhydrase inhibitors, hyperosmotic agents. So in simple language, acetazolamide and mannitol again remains the mainstay of the treatment. They can cause prostaglandin derivatives, should be avoided, but the prostaglandin derivatives should be avoided as they can lead to cystoid macular edema. Again, a very important question, cystoid macular edema. Traditional guarded filtering surgeries have a high failure rate. So along with that, I have to use the antifibroblastic agents and drainage implants. So these are again cases where if you are doing just a traditional surgery, only the filtration surgery or the trabeculectomy, it's not going to perform well. You have to think about using the antifibroblastic agents or the drainage implants along with that. Next, a very iconic thing is the corticosteroid induced glaucoma. We all know the popular mnemonic generalized tonic clonic seizures, that is GTCS, that I always tell you in the classes, that it is the topical that can lead to glaucoma and it is the systemic that leads to cataract. So whenever you are giving the patients topical steroids, you always have that risk of glaucoma in the patients. Now the topical, intraocular, periocular, systemic corticosteroid administration means it's the most common by topical, but that does not mean that only topical will cause glaucoma. Topical, intraocular, periocular, systemic, all can actually lead to decrease in the aqueous outflow and increase in the intraocular pressure, but not all patients will show it, only those who are genetically predisposed, which are the high or the severe steroid responders. So it is just the 5 to 6% that will be high steroid responders and they will show the intraocular pressure which is more than 31 mm of mercury, which is after 4 to 6 weeks of therapy. Now in contrast, all patients with POAG or low tension glaucoma, those patients who are having open angle glaucoma or the normal tension glaucoma may develop some elevation of intraocular pressure after the steroid therapy. So can you see, all those patients who are the known cases of open angle glaucoma or the normal tension glaucoma have some tendency towards this steroid respondent, and they will definitely increase, show some increase in the intraocular pressure after you are using the steroids. Now, the steroid induced glaucoma generally occurs in white, painless eye with open, normal looking angle. Optic disc cupping will be there, visual field defects, elevated intraocular pressure and the decreased outflow facility. So this clearly shows that actually these steroid induced glaucoma is a secondary open angle glaucoma, and this will going to show me all the characteristics which you are apprehending in a case of open angle glaucoma. Patients are usually asymptomatic, but acute presentation can occur if it is very high IOP, when you will have corneal edema, blurring of vision, ciliary hyperemia, colored halos and pain may occur. So, this is just like the angle closure glaucoma presentation when there is a acute high rise in IOP, otherwise it is just a secondary open angle glaucoma. Now, important thing is what are the various theories that have been given that why actually IOP is rising due to the steroids. So many theories have been given. First of all, they say that the steroids are stabilizing the lysosomal membranes and they are inhibiting the release of hydrolases. So, what is happening? The glycosaminoglycans. So, these glycosaminoglycans which are actually present in the trabecular meshwork, they cannot depolymerize, and therefore what is happening now, because they are not allowing the GAGs, glycosaminoglycans, to depolymerize, they are actually absorbing more and more water, they are retaining the water, and therefore there is a narrowing of the trabecular opening. So basically therefore it is a open angle glaucoma. Second important thing, they say that the endothelial cells which are lining the trabecular meshwork, they act as phagocytes. Right. So, these phagocytes are actually causing the phagocytosis of the debris that is present in the aqueous humor, and what is happening? The steroids are suppressing their activity. So, the steroids are suppressing the phagocytic activity, and therefore there is a blockade of the trabecular meshwork because this debris are not being phagocytosed. Again, this is causing secondary open angle glaucoma. The third important thing is that they are saying that in cases of the steroid induced glaucoma, we get accumulation of dihydrocortisols, especially the 5-hydrocortisol, and that is again causing the increased susceptibility to the elevation of the pressure due to the corticosteroids. And then they say that I think this is again an important thing, that the steroids also inhibit the synthesis of prostaglandin E and F, whose normal function is actually to decrease the intraocular pressure by increasing the outflow facility. So, they are also decreasing the synthesis of prostaglandin E and F. So, there are so many theories, but I think the nutshell of all these theories is that it is causing secondary open angle glaucoma. The use of steroids should be stopped immediately. Intraocular pressure should be controlled medically. If the patient is having steroid induced glaucoma, in 1/3 of such eyes, intraocular pressure will gradually return to normal, and rest will actually require the treatment as open angle glaucoma. So, I think you should not be careless in these things, and if a patient is showing the glaucomatous response to the steroids, one should take it seriously, one should stop the steroids at once and should start with the treatment. Then we come to the pseudo exfoliation syndrome. Pseudo exfoliation syndrome, as the name indicates, here you are having the pseudo exfoliative material. So, this exfoliative material is deposited in the anterior segment, be it the iris, the ciliary region, the lens capsule. So, they are just like the flakes, okay, and that is why it is called as exfoliative. So, it is an exfoliative material which is present over the anterior segment, okay, and particularly it is also collecting in the angle of anterior chamber, in the trabecular meshwork. They are blocking the angle of they are blocking the trabecular spaces, and they are actually decreasing the aqueous outflow. That is why this pseudo exfoliation syndrome will again be considered to be a secondary open angle glaucoma. And this material, what you are getting, the exfoliative material, is a degenerative material, and particularly you are getting it in the ciliary region. Patients with the pseudo exfoliation of the lens capsule. So, if you are having particularly the exfoliation of this lens capsule, will have a high chance of developing glaucoma. It could be a open angle also, and it could be a angle closure also. Alright. Now, see this is a very important image. This is the same image that I show you in the classes also of the pseudo exfoliation syndrome. If you are able to see these things, can you see? These are the exfoliative materials that you are getting over the iris pupillary margin. Then next is your pigmentary glaucoma. Pigmentary glaucoma is again secondary open angle type of glaucoma, because you are having the pigments in the trabecular meshwork, very common in young males, myopes. They are even having the intermittent halos. Now, again an important thing, see, whenever you are reading about the halos, it is the angle closure glaucoma or acute mucopurulin conjunctivitis, or it is the cataract. Now, there are certain exceptions where even in open angle glaucoma you can have halos, and this is one, pigmentary glaucoma. You can also have the Krukenbach spindles and Sampaoli's line. Now, when you are having a lot of pigments, you can have the pigments on the back surface of the cornea, that is called as Krukenberg spindles. You can also have the pigments along the Scholbe's line. Scholbe's line is the prominent end of the Descemet's membrane of the cornea, and that is why it is said that there are two important features of your pigmentary glaucoma. One is your Krukenberg spindles and another is Sempau-Lazy's line. Krukenberg spindles and Sempau-Lazy's line are the two important features of pigmentary glaucoma. And another important thing is that this pigmentary glaucoma is developing in 1/3 of the patients with the pigment dispersion syndrome. So, whenever you are having a pigment dispersion syndrome, not every patient will actually develop the glaucoma, but yes, 1/3 of the patients who are having the pigment dispersion syndrome will develop the pigmentary glaucoma. And another important thing is that if you are having the Sempau-Lazy's line, that Sempau-Lazy's line means that you are having the pigments along the Scholbe's line, that is actually a gonioscopic finding. So, we are not going to get it just on the diffuse examination, it is again a gonioscopic finding, that is again important. Then we have got the elevated episcleral venous pressure, because that is again contributing to the rise of the intraocular pressure. This can be caused by the elevated episcleral venous pressure, that is impeding the drainage of aqueous. This can occur in orbital inflammations, tumors, keratoconus fistulas, exophthalmos, Sturge-Weber syndrome and orbital varices. I think this will help you like anything when we will be dealing with the cases of all these things in the orbit. When you are dealing with the cases of keratoconus fistula, cavernous sinus thrombosis, Sturge-Weber syndrome, all these things will show you that there is an increase in the episcleral venous pressure, that is leading to the back pressure changes and ultimately leading to the increase in intraocular pressure. Now, first of all, try to see the cases of the intraocular tumor, how intraocular tumor can also cause a secondary glaucoma. Now, obviously tumor is important, and we should know how this tumor can cause increase in the intraocular pressure. So, this intraocular pressure, intraocular tumor can cause the secondary glaucoma not by its volume, but by its infiltration of the angle of neoplastic tissue or the aqueous seedling. Now, to be very clear, see, it's not the large tumor that is causing glaucoma. Is this the tumor, how much it is actually releasing the seedlings and which is causing or blocking the trabecular meshwork spaces. It depends upon how much it is actually for this pushing the iris lens diaphragm anteriorly. So, all these things actually make the intraocular pressure rise high in cases of tumors. It also depends upon how much compression of the veins it is causing. Okay. So, actually it is these vortex veins compression, or it is the pushing of the iris lens diaphragm anteriorly, or it is the blockade of the trabecular meshwork by its seedlings that is responsible for causing glaucoma in tumors. Then we come to a very important thing, and that is your misdirection syndrome, malignant glaucoma. Malignant glaucoma is again important because it is found in most of the cases when we have done some intraocular surgery, and this intraocular surgery has led to the misdirection of ciliary processes. So, this is also called a ciliary block glaucoma, ciliovitreal block, or aqueous misdirection syndrome. What is happening actually, if I show you very conveniently, see, this is the normal flow of the aqueous humor that is actually taking place. Normally the ciliary processes are directed anteriorly, something like this. So, whatever amount of aqueous humor is coming passes through this pupil, goes in this anterior chamber, passes through this angle, and then trabecular meshwork, say it is passing. So, this is your normal what is taking place actually, right? Now, if there is a misdirection of the ciliary processes, suppose it is something like this, they are directed posteriorly now, where you have got this vitreous gel. Okay, now instead of the anteriorly, now this aqueous humor is actually coming posteriorly in this vitreous cavity where it is actually blocked. It is blocked within the vitreous gel. That is why it is called as the malignant glaucoma, and we have this development of the cilio-lenticular block. There is formation of this cilio-lenticular block, that is why it is also called a ciliary block glaucoma. So, aqueous humor is collecting in the vitreous. What we have to do is we have to just dilate the pupil here. So, when you are actually dilating the pupil, now what is happening? When we dilate the pupil, this will be going upward. So, this ciliary body is also going upward, and therefore, these ciliary processes will also go upward. So, when they are going upward, I have now this clear space here through which the aqueous humor can pass on anteriorly, and this is the way how I treat it. So, that is why for causing this dilatation, we give mydriatics and cycloplegics. So, most commonly we give the atropine. Now, if you see regularly, atropine is avoided in cases of glaucoma. So, this is something inverse that we are doing, and that is why it is also called as the inverse glaucoma. This is also called as inverse glaucoma because normally we do not give the mydriatics in glaucoma, they are avoided, right. So, let us read. The normal flow of aqueous is blocked, and where it is blocked, the normal flow of the aqueous is blocked at the level of the ciliary body, lens and anterior vitreous phase, causing the misdirection of the aqueous humor. So, can you see there was this misdirection of the aqueous humor that you have already seen, and it is going posteriorly into the vitreous. Now, vitreous volume will increase. When there is more of the volume in the vitreous, that will push the iris lens diaphragm forward. So, it pushed the iris lens diaphragm forward, especially in the phakic and the pseudophakic eyes, okay, or it is just the anterior hyaloid phase which is going anteriorly if it is aphakia. So, it is not that it can occur only in pseudophakic, it can occur both in aphakia as well as pseudophakia, because either way it is going anteriorly, and the small hypermetropic eyes with angle closure glaucoma are actually more prone to develop this malignant glaucoma following an iridectomy, filtering surgery, laser iridotomy. It can occur after cataract surgery, capsulotomy, or even spontaneously. So, these are your important causes of the malignant glaucoma, especially the small eyes that are having the angle closure glaucoma, very prone to develop this malignant glaucoma because already their angle is shallow. Following any surgery that we are performing like iridectomy or filtration surgery or laser iridotomy, then it can occur after cataract surgeries, capsulotomies, like anything. So, these patients will complain of severe pain with the blurring of vision, and when you see the patient on examination, it will be extremely shallow anterior chamber, IOP is very high. Now, a very important thing with respect to the clinical. If you see clinically, you should always rule out the choroidal detachment or a pupillary block or a suprachoroidal hemorrhage to reach a diagnosis of malignant glaucoma. So, it is actually a diagnosis of exclusion also, because you can have a flat anterior chamber due to the coleochoroidal detachment, due to the pupillary block or the wound leakage. So, you should rule out them. Treatment, as I told you, we can give the atropine that will decrease the tone of the muscle, tautening the zonules, pulling it up, causes the posterior displacement of the lens, deepening of the anterior chamber. You can also decrease the volume of the vitreous because aqueous is going into the vitreous, increasing its volume. So, for that we can give the hyperosmotic agents. Then I want to decrease the amount of aqueous humor, because obviously whatever amount of aqueous humor is generating, it's going into the vitreous cavity. So, for that I will use the topical beta blockers or alpha adrenergic agonists, or C for carbonic anhydrase inhibitors. So, for decreasing the aqueous production, A for alpha adrenergic agonists, B for beta blockers, and C for carbonic anhydrase inhibitors, and for decreasing the vitreous we are using the hyperosmotic agents. Medical therapy is effective in some cases, but atropine needs to be continued for even months or years. Then if the patient is having pseudophakic eyes or aphakic eyes, you can do the laser hyalodotomy also. If such conservative measures do not work, you can go out for a pars plana vitrectomy with or without lensectomy, because that will certainly decrease the vitreous volume and reestablishes the flow of aqueous. Medical therapy needs to be continued for a very long time in these cases. Prognosis is better, but the condition tends to reoccur, and the other eye is also at a great risk for developing a similar problem. So, if this patient has already given you some history of malignant glaucoma in the previous case of cataract surgery, you can hope in the other eye also. So, I think this is one of the most important in severe secondary glaucoma, a very important thing, because every day we are performing some intraocular surgeries and there is always a risk of the malignant glaucoma in these surgeries. So this is all for your combined mechanism glaucomas and the secondary glaucomas. I hope this session will definitely help you, and it's very, very useful, mind you, as far as your clinical case scenarios are concerned, because every time you are solving the clinical case scenarios, you are having glaucoma out of nowhere. So what are the different mechanisms, what are the different etiologies, what are the different treatments, and what are the different causes that you have to look out, what are the different things that you will have to rule out also before taking the diagnosis are again very important. Please tell me in the comment section, how did you like the videos, how did you are going with the Parson series. Every day I am getting so many messages that you guys are liking. Thank you so much for your kind words, and this is just an initiative to help you reading the important book Parsons, so that you always have an extra edge to boost your preparation. Thank you and happy ophthalmology.